We are live.
A very good evening, everyone. Welcome to the iFocus online session, episode 468 of the refractive module. The topic for today's session is bladeless LASIK, wavefront guided, wavefront optimized and topography guided. I would like to introduce the moderator of the session, Dr. Deepa Gupta ma'am. She's done her MBBS MS from GNEC Delhi, DNB, FICO UK, and she's also been an ex-senior resident anterior segment cornea refractive surgery from GNEC. Currently, ma'am is a senior consultant cataract cornea and co-partner refractive surgery LAL 2020 Eye Care in Gurgaon. She's finished her MS Ophtha from MAMC from 2007 to 2010, senior residency from 2010 to 2013. She was previously a consultant at Center for Sight for cornea anterior segment and cataract from 2013 to 18. Ma'am is well versed and has vast experience in performing all kinds of cataract surgeries over past 10 years. She's an established refractive surgeon and has an expertise in performing all kinds of corneal transplant with key areas of keratoconus and microbial keratitis. Ma'am is an active member of various societies such as GOS, HOS, DOS, AIOS, Keracon, and Women of Ophthalmic Society. She's also presented her work at AAO, ASCRS, and ESCRS multiple times. Moving on, I would also like to welcome the chairperson of the session today, Dr. Somshila ma'am. She's finished her medical training from Mumbai and cornea fellowship from LVPI and uveitis and ocular pathology fellowship from Doheny Eye Institute, USA. Previously, ma'am was a full-time faculty at LVPI for 22 years and headed the cornea service at Hyderabad campus from 2012 to 2023. Currently, ma'am is a medical director of Shantilal Sangvi Eye Institute, Mumbai since April 23 and has expertise in cornea, cataract, refractive surgery, uveitis, and ocular inflammation. Ma'am has participated in over 20 clinical trials. She's published numerous publications in over 200 scientific journals, both national and international. Ma'am has more than 300 poster podium presentations at various national and international meetings. Ma'am has multiple achievements and awards to her name, like the Achievement Award from AAO, Best Paper in Cataract, AIOC 2012, Best Paper in Uveitis, AIOC 2019, the WOS Leadership Award in 2019, the Best Paper Award in USI Meeting 2019, Best Paper at IOIS Meeting 2019, the IRSI Gold Medal 2019, and the IGO Honor Awards in 2023. Ma'am is a member of the scientific committee of AIOS, which is the second term. Welcome, ma'am.
Thank you.
Finally, I would like to introduce our esteemed speaker for the session, Dr. Tushar Grover, sir. He's a cornea, cataract, and refractive surgeon. Sir has done his post-graduation from Arvind Eye Hospital, Madurai, and fellowship from Narayan Netralaya, Bangalore. Sir is currently a medical director, Vision Eye Center, and consultant at Sir Gangaram Hospital, Delhi. Sir has delivered over 150 invited faculty talks in both national and international conferences. He is also a recipient of awards in various national and international conferences like ASCRS, ESCRS, AIOS, and DOS. Sir has various publications to his name, including in journals like JRS, IGO, and DGO. Sir is a reviewer for journals such as IGO and AGO. Sir is also currently the section editor of refractive surgery in DOS Times. Welcome, sir.
Thank you so much.
I would like to introduce the speaker to share their slides and begin the session now.
Sure. Thank you so much, Dr. Garvita, and thank you to the iFocus team for having me here. So without wasting too much time, I'll start with the presentation. So I'll be talking about bladeless LASIK, and I'll be covering some of the advanced ablation patterns that we have now. So I think this is the first presentation in this series on bladeless LASIK. So I'll talk a little bit about that to begin with. Now, we know that bladeless LASIK essentially works using the femtosecond laser. What does femtosecond mean? It essentially means that the laser has an extremely short pulse duration, which is 10 to the power minus 15 seconds. And that is what femtosecond is. And this extremely short pulse duration essentially minimizes collateral tissue damage that is produced by this laser. So that's the advantage of having this extremely short pulse duration. Even the YAG laser that you have essentially works on a similar principle, but the pulse duration there is 10 to the power minus 9 seconds. So it's a longer pulse duration, which is why you end up with more damage to the surrounding tissues. Now, how does this work? Essentially, this produces a plasma, this rapidly expanding cloud of electrons and ionized molecules, which leads to the production of a shock wave, and that produces these cavitation gas bubbles. And it is the spread of these cavitation gas bubbles along the plane which produces the cleaving effect, which we refer to as photodisruption. Different laser machines work on slightly different energies. Some of them have a high pulse energy in the microjoules range with an associated low pulse frequency. Some of the others have a relatively lower pulse energy associated with a higher pulse frequency. But they are all essentially doing the same thing. They're all producing these cavitation gas bubbles, which help create a cleavage plane, and therefore we are able to create the flap that we need. This is the flap being created on the intralase machine. Here you have a separate suction ring that is being applied, followed by the applanation cone, which is referred to as docking. This, once you've centered and adjusted the things that you need to adjust, you create the flap. In this case, the flap has been chosen to be of 110 microns thickness. Subsequently, you raise that flap that has been created with your dissector. So this is the 3-pass technique. You do not usually want to go all the way in, because if some area is not dissected very well, you can potentially have a tear, etc. And following that, the excimer laser is used to ablate the cornea the same way as you would do in microkeratome LASIK. Following that, we reposition the flap, and then we are done. This is the flap being created on the newer Visumax 800. Here you can see that I don't need to apply a suction ring. Here it's just a single PI which is attached to the machine, and that creates the flap. This also tells you the centration from the vertex of the cornea. You can center it, then dock the eye, and this is a corneal suction. So some of the features that a femtosecond LASIK flap has is that you create a pocket which allows egress of that air which is produced. This is usually at a depth of about 220 to 250 microns. You can also customize and choose what angle of the hinge that you need. Usually we choose something around 55 degrees. If you make it too narrow, you get better exposure, but it can also make flap reposition a little more difficult. You can also choose the flap diameter that you want. Most commonly, we choose something around 9 millimeters. If you're doing a hyperopic ablation, you can go for a higher flap diameter. Even the flap thickness can be customized, and most commonly we go in the range of 90 to 120 microns. The side cut angle that you get on the flap, that can also be changed. There are some reports which suggest that having a 120 degrees inverted kind of a side angle gives you slightly better stability of the flap, and some reports also suggest there is potentially less induction of dry eye, though that's not really something which is verified, but there are some reports to suggest that. There are a whole range of femtosecond laser machines that are available now. All of them have their benefits and some drawbacks, but they're all extremely good at doing the job. All of them work in the infrared wavelength of 1053 nanometers. The pattern of flap creation can be a little different. Some of them have a raster pattern, some have a segmental pattern. The repetition rate can also be slightly different. The intralase, like I said, has a suction, a syringe-based suction with a suction ring. Some of them, like the Visumax, has a built-in PI which you apply, and then in Visumax you get just a corneal dock. So it doesn't increase the intraocular pressure as much as you would have in a conjunctival dock. All of them, at least most of them, also allow you to do additional procedures like being able to do keratoplasty cuts, being able to produce corneal inlays, and many of the new ones also allow you to do keratolenticule extraction now. Most of the machines, you also need some amount of temperature and humidity control for them to function optimally. So there are some definitive advantages of using a femtosecond laser for flap creation. One of them, of course, being that the incidence of flap complications is significantly reduced. So you are able to avoid buttonholes, you're able to avoid free flaps. All of these things can be avoided with the creation of flap using femtosecond lasers. The precision that you get in terms of, for example, the diameter of the flap and the predictability that you get in all of these parameters is quite high with femtosecond lasers, which you may not be able to get with the microkeratomes. Like I mentioned, you also have much more control and the ability to customize a lot of things, including the flap, whether it's the width, the thickness, the depth at which you're having the flap, the side cut that you choose, or the hinge. So there is a lot more ability to customize everything that you're doing. Also, in case of femtosecond LASIK or femtosecond flap creation, in case there is an aberrant flap that is created, say if there is a sudden movement from the patient, there's really no damage done because you can just redock, choose to create a flap at a slightly different diameter or a slightly different depth, and you can start the procedure again right away because you have not lifted that flap. So you have not really done any damage, even if an aberrant flap has been created. In case there is a suction loss also, it's again a lot easier to manage because you can again, even if it is a partially cut flap, you can create another flap at a slightly different diameter and a slightly different depth, and you can still carry on with the case right away. And like I mentioned, these machines also allow you to do other procedures. They allow you to make cuts for keratoplasty. You can also do intacs or other intracorneal inlays. And like I said, some of them also allow you to do keratolenticule extraction, which are added advantages of having a femtosecond laser. Having said that, there are some drawbacks as well of femtosecond. Uh, Confocal microscopy images have shown that compared to microkeratome LASIK or microkeratome created flaps, you do get higher keratocyte activation with femtosecond flaps, which is also possibly the reason why there is a slightly higher incidence of DLK when you're doing a femtosecond flap as compared to microkeratome LASIK. There is also the very obvious drawback of the additional cost that is involved, the massive amount of space that all of these machines take, and the temperature and the humidity control that you need for maintaining these machines. Apart from that, there are also certain complications which are specific to femtosecond lasers. The opaque bubble layer that is created, which is sort of like this grayish appearance that you get because of the air bubbles getting trapped in the stroma where the flap is being created, can create some issues. It can make dissection of the flap difficult. It can also potentially interfere with the pupil tracking that the excimer laser needs to do during the ablation. Other rare complications are vertical gas breakthrough, which can happen again very rarely. Sometimes you do get these air bubbles going into the anterior chamber as well. So in the image, what you see here is these tiny air bubbles that are superiorly, because when the slit lamp photo is taken, the patient is sitting, but when the patient lies down, these air bubbles come right in front of the pupil, and they do not allow the machine to track the pupil. So in these cases, you have to wait for a couple of hours, or you have to go ahead with the procedure without pupil tracking. So the ideal thing to do is to make the patient wait, let these air bubbles settle down, and then go for the procedure. Also, transient light sensitivity syndrome post-operatively, the incidence of rainbow glare has been reported in rare cases post-femtosecond LASIK, and that again is believed to be because of the higher reflectivity of the posterior part of the femtosecond flap. Having said all of this, however, and having discussed the drawbacks and these potential complications as well, the consensus now is that because of the additional safety that you get, because of the ability to customize the precision that you have, femtosecond laser is the preferred option for flap creation in today's times. So now, moving on to the advanced ablation profiles. So I'll be talking about wavefront optimized, wavefront guided, and topography guided treatments. But before we go into these profiles, it's important to discuss a little bit about the basics. What is ocular wavefront? So essentially, the wavefront is a line which is drawn perpendicular to the rays of light which are entering or exiting the eye. So if you have parallel beam of rays, you will have a plane wavefront. Whereas when you have converging beam of rays, you will have a spherical wavefront. And we often hear the word aberrations. So any deviation from normal here, in case of optical aberrations, any imperfections in image formation are referred to as optical aberrations. Now, uh, what can be the causes of it? So any imperfections, any anomalies in the optical surface anywhere in the eye can cause this. It can be because of thickness anomalies in the tear film, the cornea, or the lens. It can be because of refractive index anomalies anywhere in the ocular media, or it can be because of decentering or tilting of the optical components, such as the lens. Now, how do we represent them or classify them? So, most commonly, they are represented in the form of these orthogonal polynomials, which are referred to as Zernike polynomials. And they're classified into lower order aberrations and higher order aberrations. The, the significant lower order aberrations are the defocus, which is represented by the spherical refractive error that we have in the eyes, and astigmatism, which is represented by the cylindrical refractive error that we have. Then there are the higher order aberrations. These are responsible for imperfections in the quality of image that you get in the eye. The most significant here being trefoil, coma, and spherical aberrations. Spherical aberrations are specifically important for us in refractive surgery, so we'll talk a little bit more about it. So spherical aberrations are a fourth order, higher order aberrations. And the symptoms that you get with spherical aberrations are, one is of course night myopia, then you get blurriness, all these starbursts, halos around light. These are symptoms that you often have in patients who've undergone refractive surgery, and many of them are accounted for by the increased induction of spherical aberrations. Spherical aberrations, why are they developing? It is essentially happening because the peripheral rays are focusing at a slightly different focus as compared to the central rays. So if you have peripheral rays that are focusing in front of the ideal image point, that is referred to as positive spherical aberration. Whereas when you have peripheral rays which are focusing behind the ideal image point, that is referred to as negative spherical aberrations. If there are any doubts here, I'll be happy to clear that at any time. And again, it is the shape of the refractive surface, in our case, the cornea, which determines what kind of spherical aberrations are present in the optical system. So a prolate cornea has negative asphericity, which is also referred to as a negative Q value, and that creates negative spherical aberration. So as we know, all of our normal corneas are prolate corneas. Whereas when somebody undergoes a myopic LASIK, that cornea turns into an oblate cornea, which is referred to as having a positive Q value with positive spherical aberrations. Now, in the context of refractive surgery, we'll talk about why this is important. So the original or the conventional ablation profiles that we had some deficiencies, because of which the outcomes were slightly suboptimal. Now, in this image also, what you can see is that, the central rays are perfectly functioning perfectly with full energy. But when you look at the peripheral rays, you can see that there are some reflection losses that are happening. Also, they have a longer path length, and there is interference from the plume that is created. So the peripheral rays are not able to ablate the cornea in the same manner or to the same extent as the central rays are. And this is what leads to the induction of spherical aberrations after LASIK ablation. This is another figure which kind of represents that. So you can see that the central cornea has been ablated and the peripheral cornea is similar to the original shape of the cornea. And that's making the cornea highly oblate, which means induction of positive spherical aberrations. It was because of this reason that it was felt that there was a need to customize approaches. There was a need to improve the ablation profiles, which could give us better visual outcomes. And that is what led to the development of wavefront optimized, wavefront guided, and topography guided treatments. Now, I'll discuss all of these individually. I'll talk about the benefits, the outcomes that you get from each, and also some drawbacks of each treatment. So starting out with wavefront optimized treatment. Now we discussed how the laser pulses in the periphery are not able to ablate the cornea as well as the central pulses are. So wavefront optimized essentially just provides additional laser pulses in the periphery in such a way that the induction of spherical aberrations can be minimized. So it is just that we are aware that we are getting an ablation profile which is not ideal. You optimize in such a way that you minimize the induction of these aberrations. What is important here is that we are not measuring or treating the pre-existing higher order aberrations that are present in the optical system. We are just optimizing to minimize the induction of further aberrations. Therefore, somebody who has an otherwise normal topography or has overall low levels of higher order aberrations in the optical system is a good candidate for that. And most of us fit into that criteria. Most of us have reasonably low levels of higher order aberrations, and most of us have reasonably normal topography with minimal imperfections or minimal irregularities. So in those candidates, wavefront optimized treatment works quite well. Wavefront guided, on the other hand, is not just optimizing to minimize the induction of spherical aberrations, it's also using an aberrometer. In most cases, a Hartmann-Shack aberrometer is also measuring the pre-existing aberrations that exist in that optical system. And when you're doing LASIK, along with treating your refractive error, it is also trying to reduce the pre-existing higher order aberrations that exist in that optical system. So therefore, somebody who has significant pre-existing higher order aberrations is a good candidate to undergo wavefront guided treatment, because here there is a significant need to improve the already existing aberration profile. Does this translate into better outcomes? Most literature does indicate that yes, you do get benefits in terms of uncorrected visual acuity, in terms of the residual refractive error, as well as in terms of contrast sensitivity in wavefront guided LASIK versus when you compare it with wavefront optimized LASIK. We had also done a study where we had compared wavefront guided LASIK with SMILE, and in terms of the visual acuity outcomes, we did find that wavefront guided LASIK was better, and the aberrometric outcomes were, however, similar between wavefront guided LASIK and SMILE. There are, of course, drawbacks as well. One of them being that many of these Hartmann-Shack aberrometers are not really able to get accurate measurements in the highly aberrated eyes. Now, these are the eyes that actually benefit significantly from wavefront guided treatment, but if the aberrometer is not able to give you measurements in those cases, then that becomes a significant drawback. The other drawback is that with wavefront guided treatment, you usually need a higher ablation depth. So somebody who has an otherwise thin cornea may not be a great candidate for wavefront guided treatment. Also, when you're taking these measurements, the wavefront or the aberrometry measurements, these are measurements that you're taking at a particular point in time. So these are static measurements. However, that's not how the human eye works. The human eye is a dynamic system where the aberrations that exist are constantly changing depending on the light conditions that you have, depending on the size of the pupil, depending on how much the eye is accommodating, and various other factors. So this dynamic nature of aberrations that exists is not taken into account when you take these static measurements that you get with aberrometers. Now moving on to topography guided treatments. So like we discussed, wavefront guided is correcting the aberrations that exist in the whole optical system using the laser. The topography guided treatment is trying to address the aberrations at the most common source from which they arise, which is the anterior surface of the cornea. So here, with the help of a topographer, you are getting corneal data. You are trying to see what kinds of corneal irregularities exist on the surface of the cornea. And based on that data, you're trying to reshape the cornea into a best fit A sphere. So here you are treating the refractive error and along with that trying to regularize the cornea as well. This this essentially works with first using a topographer, most commonly a Placido topographer. In some cases, even a Scheinflug topographer is used for capturing this data, which is then fed into the computer that you assess the data in, you see if the data is appropriate, if the scans are of good quality, and do your modifications as you need to do. And then subsequently, that data is transferred to the examiner machine, which does the treatment. Now, I'll talk a little bit about how this treatment is planned, what the scans look like. I'll not go into the details of it because that can get confusing and that itself is a topic by itself. So one of the important things when you do topo guided treatment is to get good scans. There should be good coverage that you get from the topographic scan. The pupil should be small in size. Iris registration is very important because it is this iris registration which helps you compensate for the cyclotorsion that happens when a patient is sitting down versus when a patient is lying down when the treatment is being done. So it's important to have iris registration. It's important that there are no shadows in the scans. It's important also that the readings are consistent. If any of these things are missing, or if you have irregular rings, possibly because of dryness, if there is a lot of variation, or if you're not getting pupil recognition, then these are signs that those are not good quality scans and those scans should be excluded. And if you're consistently not able to get good quality scans, then it makes sense to not go for topo guided treatment. So when you look at this scan, here you can see the green P and the green R, which indicates that the pupil has been recognized, which indicates that iris registration is done. There are no shadows that you see. So this is overall a good quality scan, and this would be one of your preferred scans when you choose to treat the cornea. Here, on the other hand, you see that red R, which indicates that iris registration has not happened. So this kind of a scan you should exclude from planning your treatment. Therefore, topography guided LASIK is extremely useful when you have some irregularities on the corneal surface. Patients who have some media opacities because of which you're unable to get wavefront measurements and your aberrometer is not giving you readings, there again, topography guided treatment is extremely helpful. Topography guided treatment also gives you the ability to modify the Q value or the asphericity of the cornea and try and keep it as close as possible to the natural aspheric shape of the cornea. The disadvantages of topography guided treatment is that it is only taking into account the irregularities or the aberrations arising from the surface of the cornea. It is not taking into account the challenges or the imperfections coming in from the rest of the optical system. The other disadvantage is that when you're doing topography guided treatment, just the topographic regularization of the cornea itself may induce some amount of refractive change. So when you're doing ablation, if you're not taking that refractive change into account, you might end up with some sort of a refractive surprise. With topo guided LASIK as well, there are some practical challenges that are encountered. There are patients where it is extremely challenging to get good quality scans. In any case, you need at least 4 to 8 scans and then pick the ones that are good quality. But in some individuals, it just becomes extremely difficult to get good quality scans. And in those individuals, it makes sense to just go for wavefront optimized treatment and to avoid topo guided LASIK. The other challenge that is practically encountered sometimes in topo-guided LASIK is that the measured cylinder that the topolizer or any of your topographers that you're using in your treatment is measuring, that cylinder is different from the manifest cylinder that the patient is accepting in subjective refraction. Now, there are company-defined protocols for how to manage this, but in spite of following those protocols, there can sometimes be either some amount of residual astigmatism or there could be an axis flip that could happen. So this is something to be mindful of, especially if you're getting differences in the measured versus the manifest cylinder. And how does topo guided treatment translate in terms of visual outcomes? Most studies compare it with wavefront optimized treatment, and most studies do find that in regular corneas, in virgin corneas, the visual acuity measurements of wavefront optimized versus topography guided are similar, but the number of eyes and the percentage of eyes where you're able to get vision which is better than 20/20 or vision of 20/16 or better is higher in topography guided LASIK. Also, the induction of higher order aberrations has been found to be lower in topography guided LASIK as compared to wavefront optimized LASIK. Now, the other advantage and the other application for topography guided treatment comes not in LASIK sometimes, but in treating irregular corneas where you're doing a surface ablation to regularize the cornea. In the case of Athens protocol, you are doing topo-guided regularization using a topo-guided PRK in cases with keratoconus. The objective here is not refractive correction. You're not trying to get rid of glasses for that patient. The objective here is to give the patient better quality of vision. And in most cases, you end up with better, best corrected visual acuity. And in a lot of cases, even with better uncorrected visual acuity. Even in other cases, for example, in a case of intraoperative flap loss that was referred, which was an extremely irregular cornea, we had used topo-guided PRK to regularize that cornea, which helped improve the best corrected visual acuity and the overall quality of vision in that patient. So for these irregular corneas, topo-guided treatment is extremely helpful. Now, we've mostly discussed wavefront guided treatment versus wavefront optimized, and we've discussed topography guided treatment versus wavefront optimized. How do wavefront guided and topography guided treatment compare with each other? Unfortunately, when you look at literature, there's not too much that's available. There are very, very few studies that have actually compared wavefront guided treatment with topography guided treatment. This is one of the studies that's available where, in this particular case, they have found that the visual outcomes are very similar. They're comparable, but the higher order profile was better in the topo guided group as compared to the wavefront guided group. In another study, again, visual outcomes have been found to be similar, quite comparable, but the contrast sensitivity here was slightly better in the wavefront guided group. So I really wouldn't say that there is one which is definitely better than the other here. Both are very, very similar. Both give you extremely good visual outcomes. There are some newer developments that are present in topography guided and wavefront guided treatments. So I will not go into the details of these, but just briefly discuss them. One of these is the newer Forsidi software that's available now for topography guided LASIK. So I discussed how it can be a challenge when the topo measured cylinder versus the manifest cylinder are different from each other. And then it becomes a challenge on what to treat. So how this software helps us is that you enter the manifest cylinder, you enter the topo measured cylinder. It also takes in the values of the anterior corneal cylinder, the posterior cornea is also taken into account. You enter those values into it, and it does a vector analysis and it tells you what cylinder to treat. And this is definitely something which is extremely helpful in planning topography guided LASIK. And studies that have compared this with using the manifest refraction or the manifest cylinder have found this to be superior. You have more individuals that are able to see 2016 or better, and more individuals that have uncorrected visual acuity, which is better than the preoperative corrected distance visual acuity. Another newer development has been the ray tracing guided LASIK that has been introduced. This takes into account biometry, takes into account tomography using Scheimpflug, and takes into account the aberrometry as well. Based on that, it creates a virtual eye model for a particular individual and then creates a ray tracing ablation profile. Now, this is quite new. There is not much data available on this, not much practical experience, but so far has shown extremely promising results. Uh, it has shown a high number of individuals achieving visual acuity, which is better than 2016. A high percentage of individuals showing uncorrected visual acuity better than corrected distance visual acuity, but only with time we'll know how beneficial this is and how much value this adds over the existing modalities. So to summarize, femtosecond laser definitely does provide significant advantages with respect to the safety that you get, the minimization of flap related complications with the help of femtosecond laser, also your ability to customize the flap, the hinge, the side cut, all kinds of things. So that is definitely an advantage that exists with femtosecond laser. There are some drawbacks that I discussed. There are certain complications which are specific to femtosecond flap creation. However, despite those minor drawbacks and some complications, it is still currently considered the preferred option for flap creation. With respect to wavefront optimized, wavefront guided, or topography guided treatment, an important algorithm that can be followed is that you assess the patient by doing the refraction, visual acuity, the corneal mapping, and looking at the quality of vision. In individuals where the topography is otherwise regular or the higher order aberrations are extremely low, or you can say less than root mean square 0.3, and the best corrected visual acuity is 20 by 20 or better, in those individuals, a wavefront optimized ablation profile is going to give you extremely good results. And you don't necessarily need to consider wavefront guided or topography guided treatment. When any of these is not normal, there you can consider a wavefront guided or a topography guided treatment. If you use the aberrometer and you're able to get valid and reproducible measurements on the aberrometer, you can go for a wavefront guided ablation profile. If you're not able to get valid and reproducible measurements, you can go for a topography guided ablation profile. Alternatively, if you have the topography guided setup available with you, you can just go for the corneal topography and go for the topo guided ablation profile, because both of these give you extremely good visual outcomes. Then there are the newer developments that I briefly spoke about. You have the Forsidi software, which helps you plan topography guided treatment better and is able to get you better visual outcomes as compared to just going with the topo measured cylinders. Also, ray tracing guided LASIK is a promising modality with good initial promising results, but there is a long way to go, and with time, we'll know how beneficial it is. Thank you so much. Thank you.
Thank you, sir. That was a very lovely, comprehensive introduction to bladeless LASIK, and it has cleared a lot of basic concepts, I'm sure, for the postgraduates. I would like to introduce Dr. Deepa ma'am and Dr. Somshila ma'am for their expert comments, please.
Yeah, hello everyone. And I must congratulate Dr. Tushar on his excellent presentation and everything he could sum up and in such a comprehensive and a nice manner. I'm sure the PGs, it would really help them to understand the basic nuances of the three technologies. One thing I wanted to highlight and specifically inform them that these three modalities can never be measured by a single machine or a single console. So there are different, wavefront optimized setup, and a topo guided setup is completely different from a wavefront guided setup itself. So that was one thing. And Dr. Tushar, if you have a patient who has a high cylindrical power and probably not an irregular cornea, which modality would you prefer amongst all these three of them? Like,
Yeah, so for high cylinders, I prefer either topo guided or wavefront guided. Both work well, and the reason why I prefer either of these over wavefront optimized is the cyclotorsion compensation that you get, because that helps quite a lot with cylindrical treatments. But in terms of between wavefront guided and topography guided, I don't think there is a difference in terms of the outcome.
Somshila ma'am, would you like to say add something to it? Because we usually routinely have patients with cylinder more than three and beyond that. So which treatment modality would specific be helpful for those? Like, because topography guided, sometimes if the cylindrical part they say is if there is more than 10 degrees difference. What is your take on this one?
Yeah, so first of all, Deepa, I also agree with you. Tushar, you presented an excellent overview with three topics that you had on femtolasic and wavefront optimized, wavefront guided, and then topography guided treatment. So I'm sure that this must have at least brought in the topic to all the residents and other people who are listening to you. But of course, it's not complete. They must go back and read more because these three headings sound very similar and sound very confusing also. And just to very quickly answer Deepa's question, which she asked about higher cylinders, yeah, the tendency for most of us is to use topographic guided treatment for patients who have. That's one of the conditions where we select topo guided treatment over wavefront optimized or over conventional treatment, conventional profile, if you have, depending on which machine you have. Having said that, I also agree with you that the manifest refraction also is important. We look at that and we look at what is the corneal topography map showing us, and then I do tweak the cylindrical axis to be, if I'm choosing a topography guided treatment, then I'll tweak the cylindrical axis to match closer to the topography map. Otherwise, you cannot use manifest cylinder refraction axis and do a topography guided treatment. You won't get a good.
Exactly.
So you have to
Exactly.
yeah. So in case you've repeatedly done the manifest refraction and the cylinder is way off what you have in topography, then it means that the internal aberrations are contributing to the final refraction, internal systems, for example, the lens and so on. In which case, then you're better off if we are going with the manifest refraction, we're convinced. So suppose you have done cyclo refraction and everything, so you've cross-checked and you've confirmed that it's a manifest refraction, then those are the only exceptional cases where I wouldn't use a topo-guided treatment. So depending on which machine you have, the company themselves have guidelines, and it's really good to follow those simple guidelines on where to choose topography treatment to optimize the outcomes. One thing about the studies that have been published, so although the studies, most of them, including meta-analysis, also says that the outcomes of topography versus the other methods in terms of results, topography guided in terms of results, is fairly similar, no significant difference, except for the number of patients who had BCVA better than 20/20. That depends on, you should also look at if a company has, whose study it is. So, but if you look at it, what happens is that in any retrospective study is that our case selection is already that those corneas which are slightly irregular, what we call as, or have, we know those kind of maps that we see where there is small corneal irregularity in terms of the map. There is difference in the keratometry across a small area of the cornea itself. So those we are actually selecting topography guided treatment, which means, in other words, that for the difficult corneas, we select topography guided. And for the simplest of cases with good refraction, good corneas, good pachymetry, we select the non-topography guided, the simpler, the conventional treatment. So it means that for difficult cases, we're getting an equal outcome as per the simple cases. So in a roundabout way, we're trying to say that it's actually better when we use topography guided for these difficult corneas, but nobody has compared. So the ideal test would be to do the same treatment for both sorts of cases, the controls and cases.
So finally, I think it should be like a reserve thing for irregular corneas and maybe for a retreatment specifically. Patients who are, undergoing retreatment, redo LASIK, and definitely for keratoconus.
Yeah, I agree with you that the true value of topographic guided, pure topographic guided, where you actually customize it by changing the parameters that you're feeding in the parameters, you look at the Q values, you customize it yourself, and you change the axis and so on. That is reserved for, say, those cases where we do a small amount of ablation in keratoconus patients or highly irregular corneas, where you combine with cross-linking. But on the other hand, when you do topographic guided treatment, and we've done plenty of them for so-called normal corneas also, you get excellent results. So without any financial interest whatsoever, I would say that the outcomes of topography treatment has been extremely good. And though we haven't published this part of the data, we have published the results of topographic guided and non-topographic guided treatment and shown that it was no worse than, it was equal to in irregular and slightly irregular corneas, it was equal to conventional treatment. But the number of eyes, we have not published that part, is definitely higher, achieving 20/20 or better visual acuity with topographic guided treatments in both the groups, normal as well as not so normal looking corneas. So if you have the machine, by all means, go ahead and use a topography guided treatment. It does improve the quality of outcomes for our patients. The two questions for you, Tulika, from Tulika Srivastav to Tushar.
Yes, the first question is, sir, what is your personal preference, wavefront guided or wavefront optimized?
Yeah. So essentially, I was using the wavefront guided platform earlier, which was the iDesign Abrometer. Currently, what I'm using is the topo guided platform. So in regular cases with minimal cylinder, with otherwise completely normal topographies, I go with wavefront optimized treatment because there I don't think that topography guided or wavefront guided adds too much value. Whereas if there is a significant cylinder, or if there is any irregularities in the cornea, that's when I prefer topography guided treatment. And in my past experience with wavefront guided treatment, also I have felt that again wavefront guided treatment is particularly beneficial in eyes that have a relatively higher cylinder or have some abnormalities in terms of the higher order aberrations or corneal irregularities. For completely normal corneas, I think wavefront optimized treatment is just as good.
Right, sir. Dr. Somshila ma'am, Dr. Deepa ma'am, your choice of treatment.
In my case, I agree with Tushar. More or less, I think all of us practice fairly similarly. And most practices would also have a slight markup in terms of topography guided treatment. So there's a cost concern also for a patient. So if a patient is well suited with a straightforward refractive error, crisp endpoint of refraction, like you put this glass spectacle power and the patient refracts to 20/20 very easily, or 20/20 plus very easily, and hardly any cylinder, good pachymetry, good topography. So I would in fact say that any method you choose for the patient, your outcome is most likely going to be excellent. In the case of those patients where either my topographical map, which I mentioned earlier, is showing a few irregularities, of course, not where you're thinking of a contraindication to LASIK, but completely indicated. And so in those kind of cases with higher cylinders, perhaps I would look at topography guided treatment for these patients.
Right. Dr. Deepa ma'am? ma'am?
I'm not sure the question what
Yes.
conventional profile means.
I think it might refer to the first slide that Sir had shown before the wavefront guided and wavefront optimized conventional profile. Conventional sir, another question. Can conventional profile still be performed in patients with thin cornea and small refractive error, or is conventional profile not used at all nowadays?
So now the excimer machines that you get employ the wavefront optimized way of ablating. So conventional profile is now not available for you to treat because the newer machines, the basic what they provide is wavefront optimized treatment. Because
Correct.
those profiles were definitely giving you slightly suboptimal outcomes because of the induction of higher spherical aberrations. So that, of course, should be avoided, and it is avoided now because the machines come with at least the wavefront optimized treatment.
Yeah, as
Right, sir.
Tushar mentioned, that at minimum these treatments will try to regularize the cornea by applying more laser correction to the periphery as well to reduce the oblateness of the cornea that is induced when you do myopic. So the all machines currently conventional profile is to do the bare minimum of sort of a wavefront optimized, you can say. A couple of other points about femtosecond laser, Tushar, I thought was, though you have already mentioned it in brief,
Yeah.
is that the flexibility of creating the kind of flap depths, various depths that you would like. Also, the flexibility, say if you have, it's a more of cylinder, a higher cylinder and less myopia. So you know that the ablation is going to be a sort of an oval shape or an oblong shape. So you can also make the flap in that way. You can make the horizontal wider or depending on, and you can also change the hinge accordingly to where say if you're very, very right-handed and you want the hinge to be all the time towards convenient for your right hand. So you can do that as well. So these are several advantages that you have. Or say if you're right hand and left hand, you can put the hinge where you like. So these are some of the additional advantages. Also, for those, you guys are too young, but we started off using the microkeratome, and the sort of, it was always a roller coaster ride in terms of there's a certain fear factor. You don't know it's done till it's done, and there you have to, that's the only time
Becomes blind. Yeah, it's
in
almost blind.
yeah, so that's the only time the surgeon actually depends on the ear, because you have to listen to the cut and then the muffling of the cut and the whine of the machine, and you know whether you're in trouble or not even before you disengage everything. So that fear factor, that factor of unpredictability, which was due to the mechanical part of the machine, it was not even surgeon error, because on a given day, if the machine is not performing well, the motorized part of it is not performing well, and there were several reasons, good reasons for it. So we could have, so the flap related complications are higher with microkeratome, and it requires a lot more rigorous checks. And if you have a flap related complication, it can be most of them, all of the not so great complications where you cannot retrieve from those complications. Whereas in case of femtosecond, the biggest complication we're looking at is suction loss and usually incomplete flap. So these are the top two, I think. So in which cases you can just abort and then re-examine. You can go in deeper or you can come back another day. So there are many options when it's femtosecond. So that's what I like from being a transition surgeon and still using, at least at LVPI, we still use the microkeratome as well as we use a femtosecond laser. So although more and more surgeons are not used to microkeratome, those who practice at least in larger institutes or setups. So, but this may be so in the cities, but in rural populations or in areas where it's very difficult to maintain a femtosecond laser and an eczema laser. So sometimes it's easier to have a very sturdy eczema laser and then have a microkeratome. So in those cases, it's really heart in your mouth kind of situation. So I like that we have the femtosecond laser for that reason. Although cost really, really goes up. So yeah.
Yeah.
Worldwide, 70% is shifting. Sorry, 70-80% would be femtolasic if you look at worldwide. Yeah, I'm done. Sorry, Deepa.
problem. I'm not an issue. I just wanted to add, or rather ask, like, suppose if we have a patient and we're doing a femtosecond laser, and we have some flap adherent at a particular point due to maybe a particle going in, and we have partially dissected it, and now we don't want to continue it any longer, or maybe it's an incomplete flap, but we thought it is complete and we have kind of lifted it, which could not be lifted, so we decide to postpone. We've decided to postpone the case. So, how many days we should wait, and how to go? How do you guys like? How do you people go about it? Um,
Do you like to go first?
Most of the time, for me, I take the easy way out. As in most of these cases, I'll try my best to convert to surface ablation. So that just is a no-brainer, because then you don't have to worry about the incompleteness of the flap. And because when you recut a new flap, then the femtosecond laser is extremely precise. That's one more advantage. So it has been shown that when you recut, that means when you again apply the femtosecond laser, you will be within plus minus 10 microns of where you were earlier, which is pretty much accurate. So you can recut deeper, which also makes sense. So go deeper than the original flap. So you're very unlikely to go back in the same plane, which is the only fear that we have. So
and
how
many days we should be
long
doing?
can we wait?
Yeah.
As I didn't have too many of these complications, so maybe a week is a minimum, because most of our patients want very rapid. But when we've had such problems, I think we just there is no hard and fast, but we just wait for longer, maybe 2, 3 weeks, 1 month. I cannot give you a precise answer to that.
What about Dr. Tushar? Would you?
Even I've had these issues rarely. So a lot of times when you have partially uncut areas, I mean, partially areas where the laser has not cut, then you can go around it from different sides and eventually you're able to dissect it. Even I would, like ma'am said, prefer surface ablation as long as the refractive error is not too high. Otherwise, I would wait for 4 to 6 weeks. The cases where I have had it, I have done a surface ablation so far. I have not had a situation where I've lifted the flap partially, put it back, and then created another flap later. But I would at least wait for 4 to 6 weeks if I do that.
Yeah, so in fact, I had 2, 3 cases and I've done both the things, and both the things work well. Like even the surface ablation is definitely it is the preferred thing. But yes, one patient had to leave like India early, so we couldn't do the ablation. So we did the deeper dissection profile, and and even the flap diameter, they say if you can, reduce it to by 1 mm or 1.5 mm, it is better.
That's right.
So I think we have covered most of the things, and Dr. Garvita, and thank you, ma'am, for such a wonderful session, and I think we can conclude it now.
Thank you for having me,
Thank you.
Arvita, Deepa, and excellent, Tushar. You really covered it very well.
Yes. Yeah.
Thank you.
Thank you. Thank you.
Thank you,
everyone.
sir. Thank you, ma'am.